allows them to be treated with the right medicine at the right time and for the right duration. Partly the sponsorship around this is actually allowing that not just to understanding what context you're sitting your particular programme for development in, but also more broadly in the context not just for us in Scotland, but also in the UK and more globally with the World Health Organisation. And at the heart of all of those policy directions for stewardship is a need for better surveillance data so that we can understand what is happening with respect to the treatment of the bacterial infections that we're managing, what are the drugs that we're using, and what are the clinical impacts, both good and bad, of those treatment regimens. So if I take, for those of you who are clinical practitioners and potentially working in a clinical setting, the area I've chosen is an elderly ward, where we have 3 individual patients who have, within a 1-week period, presented with a particular infection called Clostridium difficile, which is actually often attributed to overuse of antibiotics and broad-spectrum antibiotics. So one patient has died, one is very unwell, and we have an outbreak team trying to manage what is happening in that clinical setting. Now, if we think about that from the context of information and those frontline clinicians, they need immediate, rapid information in respect to what's happening on the ground with their patients, both in respect to actually what's happening for the patients and the team, but also what's happening more broadly in respect to infection prevention strategies so that it is retained within the ward and minimised in respect to contact with other patients, but also understanding what that reporting system is within the hospital to ensure that if there is an escalation of that, how that is managed and how you bring in and inform national policy if this becomes a major event. And importantly, how do we communicate with patients and carers and relatives in this type of situation? And some of you may have experienced this in your own clinical environments. So our vision in Scotland is to think about how do we get a much more comprehensive and dynamic response capacity in the situation where we're dealing with antimicrobial management, so that we can improve patient outcomes and we can reduce harm in respect to healthcare acquired infection. So for us, the vision is really putting the patient at the centre. Now, that patient may be in an ambulatory care setting, they may be in a hospital setting. And looking to think about how does the information that we hold actually both respect to the patient, so that might be their history and their comorbidity, the previous medicines that they've taken, previous vaccination programmes, with the actual setting that they've come from. Is it a community setting? Have they just undergone surgery? Is there particular devices that may be attributing to that infection? Understanding that intelligence around the patient to ensure that we can then make the right choice in respect to both the antibiotic that we may choose or not choose to use, the infection control policies that we may use. And by better using that intelligence and having that responsive to the frontline clinical team, then we hope that we will get better outcomes and be able to understand better and monitor the actual intended and unintended consequences, not just for that individual patient, but for general policy in moving forward. So what we're trying to do with the Infection Intelligence Platform is knit that together much more rapidly and efficiently. Where did we start in Scotland? So back in, you'll not be able to read the detail of the slide, but at the top left-hand slide is a picture of Clostridium difficile frequency of cases starting in 2006 and going through to 2013. So we had a major problem in Scotland across our 30-plus hospitals and in primary care, looking at the use of broad-spectrum antibiotics and an increasing issue with the presentation of this type of infection, frequently in our elderly population. So we worked with our national clinical community to actually reduce and provide information through reports such as the one on the right-hand side, providing information back to front teams in the hospitals and in primary care to be able to allow them to look at their prescribing in comparison to their peers. And you see in the bottom chart the reduction in consumption of antimicrobials over the time period of that intervention across Scotland, and the consequent reduction in numbers of infection of C. difficile. So that was our start of trying to actually get information to the front line and change clinical practice. That was quite flat information. It was individual information around 1 or 2 systems. We then started to build informatics systems that would provide actually rapid, regular reports to our antimicrobial management teams, principally focused in a hospital setting, but they have a remit also because of the integrated health system that we have in Scotland to also look after their ambulatory care patients. And this is just a simple chart that allows an individual hospital to compare what they are prescribing and consumption of this particular group of antibiotics called the fluoroquinolones in respect to what's happening in Scotland. So they can track at a hospital level, they can track at a national level, and they can look at that over time in the context of what initiatives they may be actually introducing in their own hospital. So that was phase 2. Partly in response to our reduction in broad-spectrum antibiotics, we moved towards much more narrow-spectrum antibiotics in a response to the C. difficile reaction in Scotland. And what we then started to hear back at our National Clinical Forum was that part of that change was reintroducing the use of gentamicin and the aminoglycosides, which actually, when I started clinical practice, I did TDM on gentamicin every day in clinical practice in hospital. But actually, over the last 10 years, we have moved away from those narrow spectrum into the broad spectrum. So we took our clinical community back to using narrow spectrum antibiotics. But we started to hear through the clinical community that actually they were starting to have some concerns around acute kidney injury, particularly as we changed policy to using aminoglycosides for surgical prophylaxis instead of broad-spectrum cephalosporins. Now, that was anecdotal evidence coming to our national committee, and what we then tried to do at that point was look at the national information systems across the hospitals to see, could we validate that? And we were not in a fit-purpose state to do that at this time in 2008-9. So we did, this slide illustrates what we did in one of our health authorities where we had good integrated health informatics. And we looked at what was going through the medicine supply chain in the pharmacies. We looked at the orthopaedic surgery area, which was the surgeons that were most concerned with acute kidney injury following gentamicin prophylaxis. And we looked at our laboratory systems to look at serum creatinine, which is a key measure of renal dysfunction. And you'll see in the chart, as we changed policy, that what was happening, there was an incremental, although fluctuating, rise in acute kidney injury. Now, we'd looked at the evidence base, and at the point when we made those policy changes to go to narrow spectrum, there was very little evidence in the literature to say that this would cause a specific issue, in particular surgical prophylaxis. So on the back of that, we have recognised that that national policy of one size fits all does not work, and that actually we need to continue to understand and monitor what's happening in practice to allow us to amend and modify that. We looked at the data to check that that adverse event was not happening in other surgical prophylactic areas, and were reassured with the data that we found. We published, obviously, what we had found in Scotland. And the biggest learning story for us, and the chair of our national group, who is an infectious diseases clinician, was it was too slow, Marion. It took us 18 months from the point of signalling of clinicians saying, I'm concerned about this, to complete the national data review and make a decision and change policy. So during that time period, we had harm occurring in our Scottish population, and we needed to get faster at being able to investigate and understand the public policy interventions that we were doing. So on the back of that, we got funding. We went to our government bodies to look at how could we improve the informatics structure, not in respect to data collection, but actually in respect to how we use that data in a much more responsive way. And we're partway through that funded programme now. So we've called it the Infection Intelligence Platform, in hoping that that will bring us much more rapid connectivity of some key linked national data sets and be able to respond to policy change and understand and generate the evidence base that we require both locally and internationally to inform clinical care. So we're bringing together some key data sets. Those data sets at the moment, when we've looked nationally at what data we have in Scotland for a population of 5 million people, we have a phenomenal amount of data, and probably you have in your own countries as well, but it's poorly connected, and often what you find is there's lots of little pockets of it in lots of little data sets. What we identified as we worked with the clinical community was that there was really 5 or 6 core data sets that, if they were much more connected, would be able to answer the majority of the clinical questions that were being asked as we introduced new antimicrobial strategies, both at a hospital level and or at a national level. So we're bringing together in our platform key information from our laboratory systems that gives us, for Scotland, our resistance data. We're bringing together the prescribing data sets that we have both in hospital care, which covers approximately £300 million of spend, and in primary care, which is actually a patient-level information data set, which covers about £1 billion of spend every year in Scotland. And we're connecting that to our core, what we call Scottish morbidity record, which really looks at what activity is happening in our hospitals, because that's good clinical diagnostic information about what's actually happening in respect to both inpatient presentation, management and discharge. Why do this? So part of sponsoring this and part of resourcing this by the Scottish Government had a focus on ensuring that we had a patient focus in our policy, in respect to ensuring that individual patients got the right medicine at the right time. For boards, by providing much more rapid feedback to those boards, that we could drive quality improvement in the management of their stewardship programmes, and understand both the intended and unintended consequences of those policy changes. That at national level with the organisation that I work with, that we can understand what is that changing pattern of resistance, and for research to generate the publications to give us the evidence base for our clinicians to practice on an ongoing basis. So if we go back to an elderly patient, this time I've chosen somebody in an ambulatory care setting, in a nursing residential care, who's presenting to hospital, who's had a catheter in and has had a urinary tract infection as a consequence of that catheter and has now become septic. As they present into a hospital setting, the questions that we hope we can more rapidly answer with our platform is that we can understand what is the risk of that patient having a C. diff infection and recurrence. What is the likelihood of the antibiotic resistance that that patient may already have, having come from the community setting? What infection control measures do we rapidly need to put into place? And actually, in outcome terms, what would be and is the best treatment and outcome for that patient? So as we've built the infrastructure, we've also agreed to undertake a number of clinical exemplar studies. A number of them, because of our history around Clostridium difficile in Scotland, have been focused on understanding risk factors for that infection and the outcomes for it. And we have another number of other ones, and I'll just briefly give you an overview of a couple of them. So this first study is looking at understanding how we get a much better risk profile on patients who have had previous exposure to antimicrobials in the community and what risk is there of having a healthcare-acquired infection. And the data is not great in the evidence base and published at the moment. I don't expect you to read this, but just to illustrate that actually you need quite a clear structure study design to look at this type of association within a large clinical data set. And what we're doing is bringing together 3 key data sets: our prescribing data set, our hospital data set, and our resistance bug data set, to identify a group of patients who we can then profile and try and risk model to understand, as those patients present, given their history, what would be the likelihood of them having a C. diff infection. And we're just in the middle of doing the analysis for that at the moment. Another major challenge for us in Scotland, and one of the biggest causes of death in our hospital, is acute sepsis. And actually at the moment we have poor diagnostics coding around what is sepsis, how do we code it, and how do we therefore manage and change the prescribing policies and understand what that means for patients on the ground. So we're doing some work just now to actually get some key proxy markers for sepsis through some blood culture work. Understanding and quantifying, as we change and have changed those acute antibiotic policies, what is happening in that situation to 30-day mortality coming out of our hospitals? And is that antibiotic restricted policy doing good or harm, and how do we understand that better? So in moving forward, what we've decided in Scotland is to build on the informatics platform to ensure that our frontline clinicians can have better information at the point of clinical decision support. That in this context, for this particular area of antimicrobial stewardship, does have a locality issue in respect to the resistance patterns that they're dealing with in their individual communities. So we now have that recognised within our Scottish policy new documents that are coming through. And we also have attracted funding through our research councils to take forward the risk modelling activity so that we can actually start to get clinical decision support at the point of care for clinicians faced with this acute sepsis situation. And that is being undertaken through a new Scottish institute that's just been set up, which will also look at bringing our genomics data, both in respect to the microbiology and the human genomics, into understanding and combination with the health data as part of a next phase of our platform development. Thank you very much.
Drug shortage is a major problem and issue and concern in the Gulf country, and we have it as a special issue here, and I think the solution will be different. We have Professor Arnold Voltu, the Professor of Hospital Pharmacy and Practical Therapeutics from Erasmus University Medical Center, Netherlands, where he will talk about drug shortages and emerging crises in patient care.
Professor Ajadi. Indeed, drug shortages, drug availability is a problem worldwide, not only in the Gulf region, which is by most people seen as a very rich area, so whatever you like to have, we have the money, so we buy it. Well, that is not the case with medicines. It's the same in the United States, the same in Europe, South America, Asia, it's happening everywhere. And it's wonderful to hear the talk from Professor Benny on how she's how she's searching this kind of infection models and how to prevent them. And in the end, you may not just have the drugs to do it. And that's a sad situation. And I like to give you some ideas that I have gathered over the years on this topic. And I added a subtitle to my talk, How Business Interest and Regulation Compromise Patient Care. And I hope that it will be clear by lunchtime what I mean by that. A while ago, I took this picture from the drug shortages website from the American Society of Health System Pharmacists. At the moment, there are worldwide, everywhere, websites that are documented drug shortages and sometimes offering solutions. And I was just astonished to see here that in the United States, all of a sudden, there was no saline for infusion available anymore. How low can you go? Most simple thing that you can have is not available, even not from a big company like Baxter. They just didn't have it. They couldn't produce it for whatever reason. Usually we have to say something about our conflict of interest, and I would like to say that I have a serious conflict of interest with drug suppliers that do not fulfill their obligations to deliver the drugs for which they have the privilege of a marketing authorization. The way I see it is that we have created huge thresholds for drugs to enter the market, but we forgot to watch the back door, where they are just not delivering what we wanted to have. So I perceive a serious conflict of interest between shareholder values of these companies and patient interest that are my responsibility. I see that companies make business decisions sometimes that are definitely not in the interest of patients. And finally, I do not have any personal business interest in any pharmaceutical companies. And who cares? That's the problem. The way it's being organized is that we have a multinational pharmaceutical industry taking decisions that in the end may end up in your backyard, in your pharmacy. And the problem is that the drug shortage has no stakeholder. Delivering drugs by the pharmaceutical company, the profit they make, that's the shareholders' interest. Continuity in patient care is not relevant for most shareholders. They just look at the black digits at the end of the year. And that was the content of this editorial that I wrote for the European Journal of Hospital Pharmacy. Drug shortages have no stakeholders, so it will be very difficult to find solutions. So I will briefly elaborate on what are possible causes of the drug shortages problem. I will tell you something about my hospital and how we have been monitoring drug shortages in great detail for a period of 3 years. And I will also tell you something about initiatives that were taken by the government in the Netherlands to get a better insight in the first place on what the problem really is, and the second place, what are the consequences of that. And from that perspective, I think I may have good news. And then the problem in the end is then how are we going to solve it? Because we have to realize that we, as we are sitting here, are part of the problem. We are always shopping for the largest discount or for the lowest price. And in the end, nobody is willing to provide the drugs for that, because producing drugs sometimes is more expensive than we are willing to pay. So nobody will have anything on offer. So we are part of the problem ourselves. Drug shortages, I took this from an issue from Clinical Pharmacology and Therapeutics in 2013 that was devoted to drug shortages and every aspect out of that. And what you actually see is on this graph, is on the left side, sometimes there are quality problems, sometimes it are economic problems that the market is just not rewarding enough, and sometimes there is a law enforcement problem. And these all may work together in the end, that there's a quality problem with a drug, there's a shortage, there's a supply disruption, and in the end, you will not have any drug there. So this is in short what is happening. But in many cases, it is not just one individual factor, but they come together. And then all of a sudden, the system collapses and nothing is available. And I will go over this briefly in this presentation. And tomorrow, we will have afternoon, we will have a workshop, and there we can discuss in much more detail which different factors are there. For instance, if we look at Europe, in the Netherlands, we had quite a flourishing raw ingredient synthesis companies for raw materials, for pharmaceuticals. They became too expensive, so it moved to Eastern Europe, like Yugoslavia, then even further east. Then they went to Asia. Now they are far away in China, and we don't have any control over it. And all of a sudden, it appears that we had, let's say, 5, 6, 7 plants for production of active pharmaceutical ingredients, and we end up with one. And then that one is failing. And then nothing is there anymore. Succinylcholine, for instance, was an example that was mentioned yesterday. So, coming back to my hospital, to give you some figures of that, and I showed you the picture of it this morning, we have about 1,300 acute care beds. We have about 52,000 admissions each year. More than 10,000 people are working there. What is important is that our annual turnover of medicines is more than 150 million euros. We are the largest hospital in that respect in the Netherlands. We order about 100,000 lines of medicines each year from external suppliers, and we distribute about 300 lines of drugs in the hospital. So that gives you an idea of the size of the operation that we are working on. How do we track drug shortages? Each week we are looking at which drugs are available in our stock and which drugs may not be available if we order them. And that is a perceived drug shortage. So how are we doing it? We get this information from our wholesaler and from additional sources, sometimes letters from companies, etc. And for us, a non-availability, if we order a drug, means extra work. That's just the start of the problem. Then we look at the product involved, and each drug and dosage form and strength is counted as a unique product. We have about 3,500 unique products in stock. That's huge. The average hospital has a much smaller stock, but as an academic hospital with so many subspecializations, we need this large number. And that includes all the products from external suppliers, and they do not include raw materials and homemade products that we produce in our pharmacy ourselves. So if we follow that system, we had in 2011 about 2,500 reports of non-available drugs that regarded 266 products. As I said, we had about 3,500 products on stock. So that means that for about 10% of our regular products, we have at least once a year a situation of non-availability. And that we found was an alarming situation. About 10% of our stock was not available if we ordered it at a certain point in time. And if you look then over the years, then you see that it's going up and down, the non-availability from 10, 11 or 9, that is absolutely non-significant. And we see that the figures, well, are more or less stable. If you look a little bit more in detail, and it may be difficult to see, but on the, we see here the figures in blue, these are the reports, and the yellow, these are the products. And then you see they go up and down. And if you look at the graph more in detail, this is a 3-year period, then you see that when there are price